Good evening, everybody, and welcome to Icon Cancer Centre's Facebook Live event on brain cancer. My name's Dr. Ian Irving. I have the honour of being Icon's Chief Medical Officer, and I'm also a practicing clinical haematologist at Icon Wesley and Icon Mackay here in Queensland. To coincide with May being Brain Cancer Awareness Month, we're hosting tonight's event on brain cancer, a much feared cancer and a cancer which traditionally patients unfortunately diagnosed with brain cancer have often done poorly. There are, however, many different ways of treating brain cancer, and there have been new advancements. And tonight we have three excellent and extremely experienced speakers to talk to us about brain cancer. Firstly, I'll introduce our panel, and we thank each panelist for giving up their time this evening to come on to our brain cancer Facebook Live session. So firstly, Professor Mark Pinkham. Welcome, Mark. Professor Pinkham works at various Icon centres around Brisbane, including North Lakes, Auchenflower and Greenslopes. He's also a senior staff specialist at the Princess Alexandra Hospital in Brisbane, widely published in brain cancer and a national and international expert on the condition. So thank you for coming tonight, Mark.
Thanks for having me.
Next, we have Dr. Neha Aggarwal, who is a medical oncologist based in Canberra. Neha has specific expertise and a specific interest in brain cancer. She's also deeply involved in clinical research, running many clinical trials in Canberra, working out of the Icon Cancer Centre in North Canberra. So, Neha, thank you for coming along to tonight's panel. And thirdly, we have Vivien Biggs. Vivien has over 30 years experience working with patients with brain cancer. She is an absolute legend within Brisbane, working at Briz Brain Spine as a neurosurgical nurse practitioner. And she's going to talk about various aspects, including the supportive care of patients diagnosed with brain cancer. Thank you, Vivien.
Great. Thank you, Ian. Thanks for having me.
Thanks. The format of tonight's event will be much the same as our other sessions. The first 30 minutes, there'll be a conversation amongst our experts, and I will ask each expert various questions to do with brain cancer that correspond to their specific area of expertise. Then, in the last 15 minutes, we'll go through some of the questions that you as the audience have asked. So, either now or as tonight unfolds, please put your questions in the comments section of the Facebook Live screen, and we'll endeavour to get to as many of your questions as possible in the last 15 minutes of the event. Finally, before going into our first question, I just mentioned that, of course, there'll be a recording of tonight's event on the Icon Cancer Centre Facebook page. So if you know someone who hasn't been able to dial in live, then please direct them to the Icon Cancer Centre Facebook page, and there'll be a recording of tonight's session there for them to watch. Okay, that's very much enough time from me, and I think it would be good to get on to our experts. And I'm going to start with Viv. And the first question that I'd have for you, Viv, takes us back to as people are being diagnosed with brain cancer. So if you could explain to our audience, Viv, what sort of symptoms does someone with brain cancer present with, and when should our audience be concerned that they really need to be checked out for potentially having brain cancer?
Yeah, it's a good question, Ian. It's a bit of a tricky one. We don't, like in other cancers, some other cancers have pre-screening tools available. And that's the hard thing in relation to brain cancer. So quite often it is the patients presenting first with symptoms, and they can vary. Symptoms related to raised pressure. So the go-to is headaches. Not all patients have it, but in the case of raised pressure in the brain from the brain tumour's impact in the brain tissue, they could have headaches. They may have nausea or vomiting as the first signs. Other signs may be more related to the location of the tumour. So where in the brain the tumour is growing and the impact it's having in that particular area. So those are symptoms which could be like physical symptoms where there is a weakness in the face or the arm or the leg, and also sensory changes in the body, some numbness, pins and needles. There could be some visual loss, in peripheral vision or just in vision in general, or a loss of hearing in one side of the ear, for example. Dizziness, unsteadiness when walking. They may have speech problems, difficulty finding the right words or comprehending written words or others' conversations. And then there are the cognitive problems related to or cognitive signs related, say, confusion, short-term memory problems, attention, concentration problems, and maybe patients and families notice changes subtly in patients' personalities as well. The third kind of presentation is seizures. Patients can be quite well without very little signs at all and then suddenly have a seizure event. And this triggers, obviously, these symptoms for patients to present either to their GP or to an emergency centre and are seen by doctors at that stage. So when they present with these symptoms, cluster, straight away doctors are thinking in terms of something's going on in the brain. So that starts that whole thought of things. And those symptoms I'm describing can be other neurological problems. Commonly, it could be stroke or even dementia that a patient's actually presenting with, not a brain tumour. So when we do scans and see a brain tumour, where doctors in emergency and GPs are quite shocked by that, because it's not a rare thing. It's a rare thing to see that, as opposed to those other neurological conditions like stroke. I just can't hear you there, Ian. You might be on mute. There we go.
Technical
Sorry.
Difficulty? No, that's okay. Thanks for pointing that out, Viv. You mentioned a number of symptoms there, and of course, as you say, it can be a whole load of different symptoms that patients present with. Just to go into one symptom in particular, you mentioned headache. Now, all of us get headaches, or irregularly or at some time during our life. Is there anything about the headache due to a brain cancer that differentiates it from just your everyday tension headache or even a migraine headache?
Yes, there are some features, but once again, that can be variable with things. But certainly patients who've got persistent headaches, and some patients too that have migraine histories will often say this is different. They really notice there's a difference with it. And with that raised pressure, quite commonly patients can have headaches on waking or are woken up with headaches, or early in the morning sort of experience that headache. So they're kind of some of the characteristics of headaches when we're talking to brain cancer patients. But once again, it's not an absolute that you have brain cancer if you have a headache.
No, that's a very good point. And finally, to you, Viv, you mentioned scans in your introductory remarks. How is brain cancer diagnosed? Is it diagnosed through scans, or do people always need a biopsy after a scan?
Yeah, mainly through the scans, definitely. When you're presenting with those symptoms, as I was saying, it alerts the doctors to think, right, well, we need to get a brain scan, have a look and see what's going on. So a CT scan is what most commonly is done first to identify if there is something like a space-occupying lesion, like a brain tumour, that's causing these symptoms to happen. And then from there, we kind of go towards doing an MRI scan, because we get much more detail. And that's what the neurosurgeons are particularly interested in, is looking at an MRI scan, because it gives much more information in relation to the location where it is next, and we can do certain types of MRIs like functional MRI imaging, diffusion imaging, all this sorts of imaging that helps us plan our next step with surgery.
Great. No, thank you for that. Well, that's a great segue, Viv, as you mentioned surgery, onto the treatment of brain cancers. And first, I'll ask you, Mark, I mean, you're a radiation oncologist, and for a large part, radiation therapy is a mainstay of the treatment of brain cancer, although, of course, as Viv's mentioned, surgery and in some instances, chemotherapy and medical therapy treatments. But could you outline for us how radiotherapy is used to treat brain cancer?
Yeah, sure. So I guess radiotherapy is X-ray treatment. We all are familiar with X-rays when we have chest X-rays, bone X-rays, CT scans, and then the X-rays that we use to treat a tumour or a cancer are stronger, they are higher energy, and they pass through the area that we're targeting, deposit energy and cause damage in those tissues, and then the X-rays leave. So patients don't see anything or feel anything, and they're not radioactive afterwards. And I guess in terms of brain cancer treatment, radiotherapy is a very common treatment. It's been established as an important addition either with surgery or instead of surgery for decades, really, and it's been refined over time. I guess in terms of brain cancer, what we tend to mean is technically a higher grade glioma, but there is sometimes a bit of confusion about brain cancer and brain tumour or lesion and various other terms. And sometimes radiation might not be needed up front, particularly for the less aggressive types of brain tumours, what we call the lower grade gliomas. But for most high grade gliomas, truly brain cancers, they tend to be quite fast paced, and we tend to bring all of our treatment up front. Sometimes we use radiation to treat other types of brain tumours as well, and we have other machines or techniques. And for example, stereotactic radiosurgery is an evolution of the combination of surgery principles and radiotherapy principles to deliver very precise doses to very precise areas. But generally for brain cancers, that's not a sort of upfront tool, and the reason is that many brain cancers have a very wispy edge. They have a smudge, not a clear sort of place where they start and stop, and so these very advanced techniques where we can deliver very precise doses might not actually be helpful because we might miss the true edge of where we can see the tumour stopping.
Right. Interesting. So some of these newer techniques, though, and I might just use this opportunity to ask you about gamma knife, and in particular talk about when is the gamma knife used to treat brain cancer, and has then whole brain radiation therapy, where you would give radiation therapy to all of the brain, has that really been finished now and no longer employed?
So gamma knife is a special tool, and it's a brand name, and the sort of like the bigger approach is what we call stereotactic radiotherapy or stereotactic radiosurgery. And I love it, and I find it fascinating because for me as a radiation oncologist, it's at the intersection with neurosurgery. And we treat lots of tumours, but we also treat lots of things that many cancer specialists wouldn't get into, which is a separate discussion, but trigeminal neuralgia, various benign brain tumours and this sort of thing. In terms of brain cancer, cancers that start in the brain, gliomas generally, radiosurgery or gamma knife radiosurgery is not used up front. Sometimes it might be used if the tumour was to recur or progress, but generally speaking, it's not used up front, only in very select lower grade gliomas, and that's for the reasons that I explained. You mentioned brain metastases, and so brain cancer sometimes also means cancer that started outside the brain and spread into the brain. That's a brain metastasis or a secondary. And gamma knife radiosurgery or other precise treatments really have replaced the whole brain radiotherapy, which has been a historic treatment for decades and can help to improve symptom control in about 1 in 2 people, 50%. But the problem with whole brain radiotherapy is Well, what I explain to patients is the good thing is that you won't miss any tumours because you treat the whole brain. But the problem is that you treat the whole brain, and therefore what that means is you have to give a lower dose. And because you give a lower dose, you're less likely to control the tumours for very long, and there's a greater risk of some side effects because of the normal tissue that's also receiving that treatment.
Right. No, thank you, Mark. That's very clear. Well, Neha, I mean, medical oncology treatments or chemotherapy, immunotherapy, i.e. Medicines, drugs, have been used a little to treat brain cancer. It's often been an uphill battle, but would you be able to explain to our audience in what circumstances and who benefits from chemotherapy and other medical oncology treatments to manage brain cancer?
Yeah, thanks, Ian. So, as a medical oncologist, I get involved with the low-grade tumors and the high-grade tumors both. And once the patient gets referred to me, we look at the type of the tumor, the grade of the tumor, how much surgery they've had, and how much residual tumor has been left behind. And we usually have a multidisciplinary team where there's a neurosurgeon, radiation oncologist, and brain cancer nurse, and we look at the performance status and everything. And that then a treatment plan is been defined. So usually as radiation is the mainstay of the treatment, and the chemotherapy drug, which has not been made much progress since the last many years, which has shown to mean increasing the radiosensitivity. It's a chemotherapy drug, oral tablets, which is given along with the radiation, and that helps in improving the survival benefit for the patients. It's not, again, a curative intent, but we try to increase the survival as long as possible. So that is there are few chemo drugs which has been there for decades, and we've been using it since many, like 20 years, but there has been new advances happening recently. Earlier, we just knew about the type and the grade maximum, but nowadays we send our tissue something called sequencing, where we want to know the driver of the cancer. Is there any mutation which is driving it? Can we find a drug directly to kill the driver? So that is the new advances which is happening at this stage. And if we found a drug and we found a driver, and then we can make that clinical trial and put them on the clinical trial. So these are the new advances happening. There are many other new advances, like the clinical trials, which is happening, like delivering a drug through a vector into the brain. And in Canberra itself, we are doing a biobanking of the brain tumors, where the neurosurgeons takes like a part, and it's directly delivered to the lab, and then we multiply it and then test with various drugs. Yeah. Mute. You're gonna mute again, Ian.
Not sure what's happening there. Thank you for just, please pull me up on that. My hands are clear, but the computer has a mind of its own. Thank you so much. Can I ask you, Neha, regarding immunotherapy? Now, in a lot of other cancers, we've heard great strides have been made with immunotherapy, and it truly is miraculous to see how immunotherapy has changed cancer care. Does immunotherapy have a role in the treatment of brain cancers?
It's in a very, very specific cohort of the patients. Like we obviously tried a lot of clinical trials because this has changed the landscape of other cancers. So because brain cancer is so heterogeneous, I think that's why immunotherapy is not able to make that many differences. It did show a bit of difference in phase 1, phase 2, but when it happened in like advanced clinical trials, it did not make a difference to the response rate. So, but the patients, something called very high burden, which we again find out doing the sequencing, these patients can respond to immunotherapy.
Thank you for that answer, Neha. We'll go back to you now, Viv. We've heard about radiation therapy, medical oncology treatments, these sequencing, looking for mutations. These are all very technical aspects, but of course, as we all know, when we're treating patients are people, and the diagnosis of cancer, in particularly brain cancer, is a devastating personal event. It's not just all about the medicine. Could you tell us, Viv, and explain to the audience what are the personal, social, financial implications of being diagnosed with brain cancer?
Yes, Ian, exactly right. It is a horrific diagnosis when people are first told that they have brain cancer. They don't have the medical expertise at that stage or understanding, but when it is involving the brain, people understand that's serious. It's like an attack on the self, given all those physical and cognitive factors. So it is a bit sobering, and a little hard to hear. But as I explain it to people, it's not only dealing with a cancer diagnosis, you are also dealing with a brain injury. And that's what sets this cancer apart from all other cancers. And that's why it is so important to have the support for patients and the families that are going through this. It impacts on absolutely every aspect of their life, and including their families' lives. They often cannot work or go or even return back to work as they did beforehand. So some patients can do that, but a lot of people are affected by fatigue and the treatment and the cognitive and physical disability. The driving, they can't drive for a period of time or may never go back to driving. And that's a huge thing to have to adjust to in life. This all leads to obviously shifts in roles in the family as well, which creates a lot of stress and anxiety as well. The financial strain is huge if you're not able to work and go about earning a living. The cost of treatment as well, even in the private system and some aspects in the public, but mainly in the private too. That's what I see as well. It's a struggle too financially for all of the scans and appointments and things like that. And also there's a real social isolation associated with brain cancer. People find it difficult to continue sometimes in their former relationships and friendships as well because of the disabilities, and that sort of holds them more at home. So they're socially isolated as well with this sort of condition. So it affects everybody, and it's mainly that brain injury and those impacts we talked about before about the symptoms and how it affects the rest of the body is the real thing that sets it apart from other cancers.
Sure. No, that's very well explained, and yes, it's been very comprehensive in what you've listed out there, Viv, and that life is certainly never the same after a brain cancer diagnosis compared with before. When patients are diagnosed with brain cancer and they and their family are going through treatment or afterwards, where can they turn to for support? I'm talking about the non-medical support. Where can they go for help with these psychosocial aspects you've mentioned, Viv?
Yeah, well, this is what I'm really happy to share with everyone tonight, because this is what I do. And what's exciting about it is I've been doing this job now for 19 years. So I have seen the changes, and the change that I'm most proud about for many reasons is the support now we can provide patients and families that are diagnosed with brain cancer. That has changed. And in relation to having care coordinators now and specific to brain cancer. We only had a handful when I first started. There's many more now available to patients. We would certainly like more, and there are certainly groups that are lobbying to raise money and awareness with the government to support more brain-specific coordinators. They're not necessarily always nurses. They can be social workers. They may be occupational therapists, but they're out there helping, in relation to supporting and guiding and navigating patients' journeys. And I'm excited that landscape will change again in the future, and we will have more care coordinators. So that's the good part. And probably the biggest and most significant role, I think, has been the emergence of such excellent support organisations now that are out there. We're providing a few links for you tonight that you can go on, so you don't have to quickly scribble down all these names, because the names are quite confusing at times, because there are many out there now, organisations. But I would suggest patients go on to one that's been around for quite some time now, and I've seen the evolution of, is the Brain Tumour Alliance Australia. So that site is very easy to navigate. And one of the great things, if you click on the support organisation tab, it opens up a whole list of support organisations in various states and territories. So you can have and also a bit of information about what sort of support they provide. So that's an excellent place to start, not only to gain more information about brain cancer, but to make those connections. Myself, I deal a lot too with a national group called the Peace of Mind Foundation, which are an excellent group in relation to supporting patients. They have many events to, events, I think, very soon having a wellbeing getaway where they're addressing education and support for patients that have brain cancer and sort of targeting certain groups, whether they're carers, males or females dealing with brain cancer. So that's an excellent part of the support, but they also are part of the National Advocacy Scheme. So they help navigate Centrelink, that galaxy far, far away, which we all get very confused about at times, and help advocate and help patients direct and navigate through that system. And also with the NDIS, this is an extremely passionate group of people. And the unique thing about a lot of these organisations, and it is there with the Peace of Mind, is they've been through it already. They've been touched by brain cancer, either they're diagnosed or a family member has. So they run with such passion to make sure that they're delivering on those supports. Cancer Council, always a great go-to. There's great clinical support lines as well, for telephone lines for patients to access, both nationally and locally. And the other group, which is a group that I have had a lot to do with here in Brisbane, is a lady called Kylie Hannam, who has a foundation called All in the Mind Foundation, Craig Hannam Foundation. And we've got a link to that as well. And her real passion is the mental health of not only the patients, but of the families that are going through this. And she does an incredible job help directing patients to clinical psychology and helping them work through those adjustments in relation to this disease and the physical and cognitive aspects of it. So they've been the champions, and I hope they realise, all of those organisations out there, how much as health professionals we really are so thankful that they have done a lot of hard work establishing the organisations and helping so many people.
Absolutely. No, thank you for that, Viv. That's very comprehensive. And as you say, those organisations do fantastic work and are such an asset to patients and their families and carers. That's another excellent point. Over to you now, Mark. I mean, following on from what Viv has mentioned about the support of people with brain cancer and also their families, there has been a lot of research within Australia to improve the support given to patients with brain cancer and their families. Would you be able to outline some of this research into the supportive care of patients with brain cancer?
Yeah, because something I'm super passionate about. I completely echo everything Viv said. I think, like, we have hope for the future, but we need to help people here and now, and they have problems right now that we need to deal with. And I guess the Australian Brain Cancer Mission was a $50 million pledge over several years, and essentially this competitive grant funding brought together two large groups of researchers, clinicians and patient advocates across Australia, and we actually have a pretty strong international reputation now as kind of leaders in this field, and Australia has the sort of ability to, we really collaborate really well, and there's lots of studies out there which can be used to try and fill little gaps. So I was going to mention a few things which might supplement, I think, the much more established things that Viv has mentioned, but we recognize that people need information at different times, and there's lots of online information that's being developed and obviously trying to fit different groups of people. So for example, there's a really nice website called braintumorsonline.org, which came out of grant funding and has been let out from Melbourne, but is available nationally free of charge. And essentially it's a place where you can go and you can get lots of information, you can be connected to many other websites that Viv has mentioned, but you can also interact with other people. So you can talk to other people with brain tumour, carers can talk to other carers, There's even health practitioners on there, so you can put questions up there, and they also run webinars and things like that, so you can actually sort of receive further education if you want. And the other large group of the two was a collaboration I was involved in called Brains, which is led by Psycho-Oncology Group, and there's a website for them as well. And they had a whole suite of things. And the cool thing about their studies were that they were trying to plug little gaps. So we've developed things for memory rehabilitation, for information, for training for the carers. And one thing I think which has been really important and something which is a very clear theme is improving communication skills for health practitioners. So there are many people who will maybe in the first hour of talking to them, just the first thing they'll tell will be how they recount how the diagnosis was relayed to them, what they learned, how they felt. And they might not remember all the facts, but they'll certainly remember how they felt and how that experience went. And actually, I think something that we're trying to do better is actually upskilling the people delivering the information to adapt that to the person and obviously make that fit right so that they get the information they need. But obviously we don't, I think, completely dash all hopes straight away.
Yes, no, excellent. Thank you, Mark. No, it's great that Australia leads the way in this research into supportive care, and because as important as the science is, and as Neha mentioned of the sequencing and looking for driver mutations, the actual support of patients and their families right here and now is equally important. Before we go on to questions from the audience, and as I mentioned at the start, if you do have a question, please put it through the chat and we'll endeavour to get to as many questions as we can in the next and final 15 minutes of tonight's event. But before we go on to the audience questions, I just want to go around our panel quickly one more time, and starting with you, Neha. Could you just, and I'll ask the same question to each panel member, could you outline for a patient newly diagnosed with brain cancer, what are one or two things that should be foremost in their mind and that they should ask their treating physicians?
I think the first question is knowing their team, because it's like they're seeing three departments: neurosurgery, radiation oncology, and medical oncology. So I think they should understand that we all work in collaboration and their case is discussed between us, rather than thinking there's a separate doctor and we're not talking. And so they should have that trust that there's a multidisciplinary team which is working towards their cancer diagnosis. And other than just the medical issue that they have, they should ask us that what's the support system as we provided? Is there palliative care involved in their team? So I think those things patients should understand that we all are working in collaboration. Yeah.
Right. No, thank you. Viv, if what would you say to a newly diagnosed patient with brain cancer? What should they be asking their treating team?
Yeah, it's an interesting one. I just thinking, Mark, as you're talking there, that's my job, is talking to the patients with, when the diagnosis is known. So I feel great when I leave and they've had their list of questions and they've gone, you've covered the majority of those. I might have missed a couple of them, because it is an art. It takes a while to learn how to do that the right way. So I always say to patients, still a good way to know that in your first encounters when you've been discussing the tumour, it's to know where basically what is the name of the tumour that I have. Is it a benign or malignant tumour? And also, where is it in the brain? So I think a bit of detailed information around that, and when we have the diagnosis, learning a little bit more about the tumour itself is empowering for patients. They don't feel like they're in control. So the more that you give them, at times they can have that sense of control. And also what treatment, when you're giving that news, it's also wanting to know from patients' point of view, the next questions always line up as to what treatment is recommended from here after surgery. And I think a good one to ask is always, what are the goals of that treatment is going to be? Is this going to be something that we're aiming to cure? Or is it something that we're looking at trying to hopefully control for as long as possible? And I think that's important for patients to know.
That is such wise advice, not just around, of course, brain cancer, which is the topic of tonight's Facebook Live event, because, of course, May is Brain Cancer Awareness Month, but for all cancers, I mean, all medical diseases really, clarifying that treatment goal with your treating physician or treating team is so important. And sometimes talking to, you know, the audience now, if that can be hard to do on the first visit, but certainly early on, it's very important that you as the patient and the treating doctor are on the same team with goals aligned, because you just either side of the doctor's table can assume things, and assuming a goal of treatment, you know, it can be dangerous. So important to clarify that.
Yes.
Yeah, thank you, Viv. Now, Mark, before we go on to questions, do you want to give our audience your one or two tips for what should a patient ask when first diagnosed with brain cancer?
Yeah, I think I completely echo what Viv and Neha both said, actually, but I think it's very clear to me that when someone hears the diagnosis, it's a tumor, it's a cancer, their eyes glaze over and they're probably not going to remember anything else that you've said in that whole consultation. So the thing I would say is it's definitely okay to ask the same question again, because you might have asked the question and you might know that they know that you asked the question, but you don't remember the answer, and that's okay. Sometimes if you ask another person or another doctor or another practitioner the same question, you might get a slightly different answer, and that's okay too. Sometimes we don't know and we're giving you a best guess. So if you hear something and it's confusing or confronting that they've said something different, ask them why. Ask them, oh, so-and-so said something different. I'm not saying that you're right and they're wrong or the other way around. Can you just explain to me why there might be a difference? Because sometimes you hear things that I think might be not correct, for example, to the individual, but might be the kind of average for an average person, whatever that means. And so sometimes you might get different levels of granularity of detail, which might actually end up causing more confusion. And the second thing is very quickly would be to say to people, okay, what can I do to help myself? Is there stuff that I can do that's within my control to help? And for some people that might be exercise. Some people might have questions about diet, and obviously there may be some extremes there, and so talking to your team about sort of what is right, what might be recommended, what might not be recommended is good. And that also applies for people that might be interested in exploring supplements or other kind of integrative medicine approaches. That's all fine, and but it's just important to talk to the team, make sure we all know, and particularly to think about interactions or potential unexpected consequences of not knowing that someone might be taking other things.
Sure, and I will get on to everyone's questions, but Mark, I'll just probe you one step further on that. You mentioned about the diet and exercise for when you have brain cancer. What advice do you give patients about what sort of diet they should be on for brain after being diagnosed with brain cancer? Is there a specific diet that helps with the treatment of brain cancer?
I think the short answer is no, but what my answer would be is I think it's important to have everything in moderation. And the thing that people are more prone to do is to have, you know, lots or very little of something. For example, sugar. There's certainly some, you know, suggestion that sugar may have a role in cancer development, and we know, for example, in kids that have intractable seizures, that going on a keto diet can actually be part of their management plan, their medical management plan. So there's something in it, but a keto diet is actually quite hard for patients to stay in, and it may actually compromise their ability to tolerate their other treatments. So I think everything in moderation, plenty of colors, plenty of different things. The occasional cheat food is fine, you've earned it, and the occasional drink of alcohol in most people is probably okay as well, and try and avoid the extremes.
Sure. No, thank you, Mark. That is a great segue into our first question tonight, and I'll address this to you, Neha, and it involves around seizures, following on actually what Mark said about the control of seizures. And the question is, when someone has brain cancer and if they have seizures, how are the seizures treated?
So we are usually these patients are usually linked with our neurology team, and sometimes the first presentation is seizures, and they're prone to have seizures during their treatment. So we usually start them on anti-epileptic drugs on to manage the seizures, and sometimes we need optimization of the dosage over the period of time. So this is the main management to start on anti-epileptic drugs. Yeah.
You're on mute, Ian.
And there are quite a variety of anti-epileptic drugs out there too, I think, Neha.
Yeah.
That will be individualized for each patient.
Patients, yeah.
Following on from seizures, but not exclusively talking about seizures, Viv, what are the rules around Australia with respect to patients with brain cancer driving a car?
Oh, I got the hardest question. I know, and I'm not trying to make fun of it, but it is one of the more difficult parts of this whole journey for patients. Basically, we've got neurosurgeons are the ones where it usually gets asked that question because they've had neurosurgery. And it basically depends on where the location of the tumour is. So we do have the OS road rules, which are some guides in relation to all medical conditions. And in there is obviously a section on craniotomy. So that's when we actually open the skull and go in and do surgery. And the recommendation there is around 6 months of no driving after a craniotomy. And that's related to the seizure risk, whether you're on medication or you've had a seizure in the past or have not. It's more the surgical procedure that holds that back. So a lot of times other doctors will turn around and say, well, you've got to go and ask the neurosurgeon. So it ends up with that. In our practice, we like to involve a neurologist, of course, and often refer patients for an EEG and a review and examination by a neurologist prior to making that decision of whether they're able to return to driving. But once again, that's under some very strict guidelines of if they shouldn't be driving when they're fatigued, short distances, obviously, as they're first starting back to driving. And of course, if they have a scan again that shows some changes, then they need to be reminded that they need to stop driving until we have control of the situation again and get that clearance. So medical clearance is pretty important. And certainly one medical clearance is given where they can write up a medical clearance form that goes to the transport up here in Queensland. Queensland Transport will then put a condition on the license, and that's reviewed every 12 months. So that's the proper way to do that process.
Right. No, thank you for that. And you're right. It is. Yes, it is a difficult question, and of course, these rules are slightly different in each state.
They are, yeah.
Yes. Mark, we've had a question from an audience member about how precise is modern day radiation therapy for brain cancer? And I think you touched on this before, where because of the hazy margins in brain cancer, sometimes you actually don't want to be too precise. But putting that aside, how with these various techniques, to what sort of precision do you get radiation therapy to the brain these days?
So I guess the short answer is that it's in the range of a millimeter or so. The way we design the radiation for a brain cancer is normally to use an MRI scan, which most people will be able to have. And then we define the area that we want to treat. And for many brain cancers, because of this infiltrative wispy edge, we might add a bit to cover the microscopic extent that we can't see. And then once we're happy that that's the volume we want to give radiotherapy to, the precision in most cases is going to be in the range of a millimeter or two. And it will vary a little bit depending on the type of equipment and some other factors, for example, how still a patient can lay. But for most cases, it'll be pretty precise. The idea is that as the beams come through and bring their dose, where the beams overlap, that's the bit that gets the most dose, and then all of the lower dose around it is dropping away. And so you might have the dose dropping away quicker in one direction than another in three-dimensional space. And I guess the art, not the sort of science of radiotherapy for brain tumors, is trying to work out, like a surgeon, where, like, how you can get to the tumor and cause the least damage or trouble, and obviously trying to limit the dose more to very sensitive areas of the brain, or more sensitive areas of the brain. And so, you know, the dose will drop away very quickly, but even beyond the tumor, there will still be lower doses passing through to get there.
Sure. No, thank you. It's a very nuanced answer, so thank you. We've come to the end of our 45 minutes, so I'm going to finish the session by going round our panel once more, just asking them to give one or two sentences as a closing remark. But before we do that, I do just want to make mention there have been quite a few questions put through the chat function tonight relating to very specific circumstances, very specific treatment-related questions, often of a personal nature. And our team will reach out to those people who have put those questions during the next few days after the event, and we will answer them as best we can and point you in whichever direction we think is best. But we thought it best that such personal questions are addressed individually rather than on a Facebook Live event. So just in closing now, I'll start with you, Neha. Just if there's any one or two sentences you would like to give to the audience as a summation on our brain cancer special tonight, and I'll go around each panelist before we close.
I would just say that the gliomas are quite medically complex and it's quite emotionally challenging for the patients. But there are many supports available. There are lots of recent advances happening, and we are trying our best to make our patients live longer in a well-supported manner.
Oh, you're on mute, Ian.
Viv?
Yes. Yeah, I'm reminded when I first started this job, reading a book called Living with Brain Tumors, written by a neurosurgeon. And in that book, it's what I've based my whole entire career on, is he was talking about dealing with learning about, you know, statistics about brain cancer and how to deal with that information. And he said a very profound sentence of, "You are the statistic of one." And that's what I share with my patients all the time. I champion that one, as in that how you respond to the treatment is your own personal journey. No one else in the world has your DNA. We provide this treatment, and everybody's experience can be different, and you can actually, achieve even within the malignant diseases, good outcomes and long-term survival, and what's important, that quality of life. So it's about not losing hope in this, and I think, you know, that that's been echoed tonight, and I'm really, really happy that hopefully patients will take that home tonight as well.
Wonderful. No, exactly. We never want anyone to lose hope. Mark, the final word over to you before I close the session.
Yeah, look, I think it's a privilege to care for people with brain tumours. They're very special. I'm very passionate about it, and I think the other panel members are too. It's the threat to self that Viv started with. I think it's different, and people always say, "Oh gosh, that's a pretty heavy area to work in. How do you manage?" It's like every day I meet people who are having the worst day of their life, and I can help them. And I think that's the hope that we have, and I hope that hope translates to patients as well. I think information is important, but you've got to have hope.
Right. Thank you, Mark. And as I close the session, again, I very much thank our three panelists, Mark, Neha, and Viv, for giving up their time tonight. To you watching at home, a big thank you also for tuning in. Again, I just remind everyone that a recording of tonight's event will be on the Icon Cancer Centre Facebook page, so you can direct your friends, family members to watch the session on the Icon Cancer Centre Facebook page. From myself, Ian Irving, Icon's Chief Medical Officer, I wish everyone a good night. We look forward to everyone tuning in for our next Facebook Live event in a couple of months' time. And I wish everyone the best of luck and ensure you have a good night. Bye-bye.